We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating today's session. For those of you who are new to Project ECHO, it's a healthcare initiative that originated at the University of New Mexico as a means of equipping communities with the right knowledge at the right place at the right time in addressing hepatitis C challenges. It's an all teach, all learn, interactive guided practice model of peer-to-peer learning and collaborative problem solving, and we'll be capitalizing on that model to address COVID-19 challenges in skilled nursing facilities. A few announcements before we begin. First, if you've not registered for this series, please do so. We'll share the registration link in the chat. If you've not already done so, please put your name and email address in the chat for our record-keeping purposes. We ask that you stay muted during the session. You can use *6 on your phone to mute and unmute, or the microphone icon on the bottom of your Zoom screen, but you can also use the chat for communicating. Of course, when we are in the discussion section of today's session, you can feel free to unmute your microphone whenever you need to. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible, but we do follow up with any open items after the session. Please remember that if we're discussing cases, no personally identifiable information or PHI is allowed. We are recording these sessions, and we share all materials and recordings after the session. In the spirit of ECHO's all teach, all learn approach, we will be on a first name basis during the sessions. Our ECHO sessions always begin with a brief lecture, and they're followed either by a case discussion or questions and answers. Today's session is a brief lecture on when to discontinue transmission-based precautions in your patients and when to allow infected staff back into your facility. And that will be given by Dr. Ayesha Ahmad. And then we'll follow that with a question and answer. So please feel free to put questions into the chat as we're going along. We'll categorize those and pull them into the discussion when that part begins. Remember, this is all teach, all learn, so everyone can share both questions and answers. And in the interest of time, we're not going to do introductions, but I'm going to ask that as you interact during this session today, please go ahead and announce yourself by name. And with that, I'll turn things over to Ayesha, and she'll start us with her lecture and introduce herself.
Thank you. Hello, everyone. I am an internist and geriatrician with Penn State Health, and my realm of practice is both inpatient and skilled nursing facilities. I work on behalf of Penn State Health with a number of local nursing homes in the Dauphin County area. And some of them have really been affected by COVID. So it's been an interesting experience. I'm sure some of you have attended these ECHO sessions, and I will not go into too much detail, but we try to keep things simple. These are not hardcore medical lectures. They are meant for a variety of staff who work in the skilled nursing facility setting. And obviously this particular series has to do with COVID-19. So for today, I thought we'll revisit when to discontinue transmission-based precautions in both patients and healthcare workers. And it's hard to talk about this topic without touching a little bit on the testing guidance, on zoning, and then when do you declare a zone recovered? So I'll be sort of touching on all these topics briefly. So COVID-19 is really affecting skilled nursing facilities, not just across the state, but across the nation. Nationally, a large percentage of all COVID deaths are linked to skilled nursing facilities. If you talk about our state, Pennsylvania, as of yesterday, the total number of cases of COVID in nursing homes was about, in the state was about 115, or nearly 116,000. And the total deaths were north of 7,000. when we project that data on nursing homes and assisted livings, the total number of facilities affected are about 867. And if you're curious, there are nearly 1,200 facilities across the state. And we've had a number of deaths, unfortunately, as you can see on the screen. So in Pennsylvania, nearly 68% of all deaths that have happened in the state have happened in either assisted livings or in skilled nursing facilities. That to me is a very sobering number, a very sobering statistic. So I'm going to be talking a little bit about testing, zoning based on both reactive testing and surveillance testing, and then when to DC transmission-based precautions, both in patients and when to allow your healthcare personnel back to work. I think a lot of you who work in different facilities have been inundated with what we call the PA Health Alert Networks, or PA HANs. You know, there've been a series of those coming since the pandemic started. This is the one from early June, which talked about, massive testing across nursing facilities for both patients and for healthcare workers. So before we talk about testing, let's not forget that we're going to not forget the basic infection control guidelines. As you remember, we limited visitors starting March 13th for all our SNFs. We limited or stopped communal dining, group dining, all recreational activities that require grouping. We are closely monitoring all residents for symptoms and signs. We are closely monitoring healthcare personnel as they enter and exit the facility for symptoms and signs, and we mandate universal masking. Now we'll move to testing. So testing is either reactive when you have a new case, right? Anytime you have a patient who runs a fever, has a cough, or has some other atypical features of COVID, you do a test. You send it either to the DOH or the lab that your facility has a contract with. And then based on that new patient who is a patient under investigation, the directive is to test people who may have been exposed. So that is the reactive testing. In addition to that, a lot of facilities have been required to do what's called universal or mandatory testing based on Governor Wolf's universal testing order, which was issued for nursing homes on June 8th, 2020. Based on that, all skilled nursing facility residents and staff were required to be tested at least once before July 24th. That data is actually on the DOH page, and I reviewed it yesterday, and I think a large number of facilities across the state have met that guideline already. When you're doing universal or mandatory testing, you really should not be testing people who have been previously COVID positive. So I seem to skip a slide each time. So follow-up testing or surveillance testing. So what's recommended for facilities that are battling COVID outbreaks is that all residents and all healthcare personnel in response to a new case should be tested. And you should continue repeating previously negative residents at a minimum once a week until the testing identifies no new cases of COVID-19 among residents or healthcare personnel for at least a 14-day period. If your testing capacity is limited, which I think every regional nursing home has faced some issues at any given time, then you should at least repeat testing for high-risk people. For example, people who go out to dialysis, people who are co-followed by the wound team, patients who are going to appointments multiple times that is still needed in the COVID age. So you may want to reduce the cross-section of your surveillance testing for high-risk patients if your testing capacities are limited. But ideally, if if you had all the resources, then based on one positive case, you should be testing all personnel and all residents at least once a week. So I'm sure all of you are quite familiar with the zones. This guideline came along with the testing guideline in late May, early June. And hopefully your facilities have been zoned appropriately. So I'll just briefly revisit what these zones are. A red zone is a COVID positive zone. A yellow zone is a potentially exposed zone where you have patient who had a negative SARS-CoV-2 test and are asymptomatic, but are within 14 days of exposure to COVID-19. So an example of a yellow zone would be a unit or a hallway where new admissions come from the hospital or frequently go out for dialysis, etc., or patients who may have been exposed, tested negative, and are yet asymptomatic. And a green zone is, of course, our ideal aspiration. This is where we want our patients to be, or where we want our facilities to be, which is everyone who, even previously, if they did have COVID, is now completely recovered, or this zone has been COVID-free throughout. So staffing across zones, ideally, you should consider using one set of nursing and aides for each unit, and there should be minimum crossover. That's ideal. We all know that in the midst of the COVID pandemic, we had severe shortages of healthcare personnel. Some nursing homes struggled to the point that National Guard had to be called in. So we all understand that each facility, depending on where it is in the pandemic crisis, may face a point where things may not be ideal. But if you do have enough staff, then you should have one set of staff always working on the same unit and not cross over. So COVID staff should stay committed to COVID patients. Yellow staff should stay committed to the yellow zone, and the green staff should stay committed to the green zone. Less ideal than that is that staff may cross areas, but they should not do it in a single shift. And what should never happen is staff that should work with COVID patients and then come back and work for non-COVID patients. That would be the least ideal setting. So ideally, again, your green area should be far away from your red area, right? And your personal protective equipment in the green zone is different than in the yellow zone. So first of all, if you're working with COVID patients in a red zone, you should be wearing your full PPE. You should be wearing your gown, your N95, ideally a face shield, gloves, and you should be changing all of that after each patient encounter. If you're working in a yellow zone, the DOH recommends you should wear your full PPE. But in real life, wearing an N95 in the yellow zone may not always be possible. So sometimes the full PPE could mean that you're simply wearing a surgical mask with a face shield in a yellow zone. And when you're in a green zone, you're not dealing with COVID patients, so you should just do the basic infection control that you would do under normal circumstances. So I think a lot of you are facing the issue that you have done either the mandatory surveillance testing based on the governor's order, or you've done surveillance testing after initial outbreak, and your patients who were previously negative and had no symptoms suddenly come back and have positive results. What should you do? So I think by this time, if most of the facilities who have faced COVID should be pretty adept at that. What you really need to do is you need to start moving these patients who have a positive test to a red zone. You should be testing their roommates. And you should make an area in your unit, preferably the back of the hallway. I mean, every facility is different. So you also have to consider that it needs to have a separate entry and exit. It needs to have separate bathroom facilities for the nursing staff and for the aides that work in the red zone. So all of that has to be taken in consideration. But what you really need to do next is you need to cohort the positive cases, make it a red zone, and then the remaining hallway and unit, which are potentially exposed patients, but tested negative and are not showing any symptoms, automatically become a yellow zone. If the patients who had tested positive are physically removed from a green zone, your green zone can stay a green zone. It may not be affected. Every facility is different. Some are, have hallways that connect. Some have staff that spill over into hallways. So I think you'll need to weigh in all those decisions. So when do you declare your zones or your units recovered? Well, first of all, you don't go in reverse order. For example, a red zone doesn't turn into a yellow zone and then turns into a green zone. Basically, both red and yellow zones turn into green zones. When does that happen? That happens when you have not had a new case and 14 days have elapsed at least. So another scenario that may come up is you have a whole slew of patients who tested positive for COVID, regardless of whether they have symptoms or not, and they have all been cohorted the best you could have into a red zone. Now, what do? Do you begin to move each patient that meets the criteria to discontinue transmission-based precautions one at a time to the green zone? Or do you kind of wait and, wait for the entire unit to recover within a few days of each other? Remember, when people are tested for surveillance or mandatory testing, usually that testing happens, that entire sweep happens on one single day. So it's kind of easy to remember that if you tested positive on, let's say, the first, right? You can probably discontinue transmission-based precautions on a large number of these patients by day 10. And even if some of these patients eventually did develop symptoms or moderate to severe disease, you could stretch it to day 20. So what would probably be most reasonable, instead of switching patients back and forth too frequently, is to keep the recovered residents where they are and then aim to transition the entire unit to a green unit, which should happen within a span of a few days if the testing happened all together. But if you happen to have patients, which in some of my facilities we had, when we had an outbreak, we would have a patient test positive one week, then 2 other patients showed symptoms the next week. So this system of declaring a zone recovered becomes far more complicated when, when you've had an outbreak where people tested positive days after each other. So again, to de-escalate zones, you do have criteria set out in PA Hand 502, which I'll go over in the next few slides. But basically, you don't go back in a spectrum. You basically turn a red unit and a yellow unit to a green unit when all the criteria have been met. So what are those criteria? All residents on the unit who had confirmed or were probable cases of COVID-19 have met the criteria for discontinuation of transmission-based precautions. At least 14 days have elapsed from the last positive test or the last presumptive positive. At least 14 days have passed since the implementation of transmission-based precautions for COVID-19. All residents who were not confirmed or probable cases of COVID-19 remain asymptomatic. All residents who were not confirmed remain asymptomatic. All staff remain asymptomatic or have met return to criteria work. And no additional or ongoing exposures have occurred in the meantime. So, these are every unit that you turn green from either red or yellow has to basically meet all these criteria. Mind you, if you have a hallway or a unit where patients are frequently going out for dialysis, or you're accepting a lot of new transitions from the hospital on a regular basis, that unit may stay yellow for a long, long time to come. So now let's kind of revisit when to discontinue transmission-based precautions. This has changed a little bit because I'm sure that the new PA Hand that came out on July 18th has really discouraged test-based strategy. So back when the pandemic started, these were the guidelines set out by CDC, which the DOH is also having us follow. And those guidelines were that if you had symptomatic COVID as a patient, what we should do is we should either wait for resolution of symptoms and then 2 negative tests, PCR tests, back to back within 24 hours of each other. And if you were not using the test-based strategy, then at least wait 10 days since the onset of the illness and wait a minimum of 3 days after symptoms have resolved, which means you don't have a fever, you don't have a cough, you don't have shortness of breath, you don't have any GI symptoms anymore. If your patient was asymptomatic and tested positive, then you do 2 serial negative tests. The question is when. Ideally, you should wait at least 7 to 10 days. And then if you're using the non-test-based strategy, you should wait 10 days since the first positive test. It would be highly unusual for someone to become symptomatic after day 10. So on July 18th, DOH, based on new guidelines from CDC, basically said that we no longer recommend test-based strategy to discontinue transmission-based precautions. And the reason why this came about is that a lot of us were seeing patients who had complete resolution of symptoms, complete resolution of fever, but continued to have positive tests. I know personally some patients I took care of in nursing homes that tested positive on day 54, which was making no sense to us. And we would, run this by our infection control and infectious disease specialists. So it turns out that CDC, based on a lot of data, is finding out that people who continue to shed remnants of the virus envelope in their noses are generally no longer infectious, to other people. So that is why they have been focusing on discontinuing the test-based strategy and only to continue time-based or symptom-based strategy. So the new update is that if you have a symptomatic patient, you should basically wait 10 days for your minor symptoms and 20 days for patients who have moderate to severe disease. And you should wait provided all their symptoms have resolved and have improved. If your patient never develops symptoms, then 20 days is enough since the first positive test. I'll tell you that we kind of tweaked this and made this day 21 in a lot of our facilities. You know, your institution may help you with that, but according to the CDC and according to the DOH, the current guidelines are 20 days with resolution of symptoms, or 20 days regardless of symptoms if you're dealing with an asymptomatic case. What about healthcare personnel? A lot of our healthcare personnel, from nurses to aides to dietitians to physical therapy staff, have unfortunately been exposed or have had COVID. So when do we allow them back to the facility? So again, first of all, we should be monitoring all healthcare personnel for symptoms and signs, both at the beginning and the end of their shift. Anyone who develops any symptoms should basically be sequestered from work right away, should be tested. And mind you, according to both the governor's mandate and the DOH recommendations, we do recommend testing healthcare personnel who have previously been negative every week. We know that that's not happening in a lot of facilities, but ideally that's what we should aim for. So the old guidelines for allowing healthcare personnel back to work were, if they were symptomatic, wait for their symptoms to resolve, and a minimum of 10 days have elapsed. And if you were using test-based strategy, then you wanted resolution of symptoms along with 2 serial tests that are negative 24 hours apart. If you happen to have a healthcare worker who never developed symptoms, you should wait 10 days since the first positive. And if you know, the old guidelines stated that they should have 2 serial tests back to back, which were negative if you were using the test-based strategy. So just like the CDC has updated the policy for declaring patients recovered, which is non-test based, they are recommending or encouraging the same for healthcare personnel, which is we no longer recommend a test-based strategy. So healthcare workers who had a severe illness, who are severely immunocompromised, they are recommending exclusion for work for about 20 days since the symptom onset or after their first positive test. For all others, they are recommending 10 days, and at least 24 hours should have elapsed since their last fever, and their symptoms should all have improved. So some of the verbiage has changed. Their symptoms don't have to resolve completely, but they should have improved. So that was just a quick overview of reactive and universal testing, zoning that automatically ensues from the testing results, and then when to declare both your patients and your healthcare personnel recovered. I'll be happy to take questions.
So Dr. Ahmad, there was one question that came in a few slides back. Claire had asked, shouldn't staff in the green zone be wearing a mask and safety shield?
So mask Surgical mask for sure. Safety shield is not recommended in the green zone by DOH yet, but I'm telling you it's coming soon. And from my experience, we have tried to wear the shield even in the green zone in the facilities we work at almost all the time. And I think if you follow Dr. Fauci, I think this is a recommendation he made last week in one of the interviews. Interestingly, only yesterday, our hospitalist chief emailed us that these changes may be coming soon, that just like a surgical mask is now mandatory for healthcare personnel, whether we work in a hospital or a nursing home, they are looking to see whether they should do the same for a face shield or goggles. So I think that's a great question. I would recommend a face shield or goggles even in the green zone, yes. I think a lot of transmission happens through our eyes, and when you're dealing with sort of an outbreak, not just in your facility, but in your community, and especially if you're a healthcare worker, you want to make sure you keep yourself safe so you don't, not just to prevent illness in yourself, but to prevent illness in all the elderly, frail patients you'll be exposing.
So we do have quite a few people who've participated in our other COVID echoes. So I would encourage those who are more familiar and comfortable with the environment to feel free to ask questions or pose discussion items. Ayesha, also, if you have questions for the participants today, that would be wonderful.
Hi, I'm Dr. Asavala. I work with Dr. Ahmad, and that was a great presentation. I had one observation. I'm leading the medical aspects of the South Central RICB, and so we've been out meeting many of you. And we've had a few occasions where a staff member who was asymptomatic through the universal testing tested positive, and then for one reason or another, a few days later had a repeat test that was negative. And then the question came, well, now they're negative, so can they come back to work now? And the feedback is that once you have the positive, there's no value in repeating a test if it's negative. Once you have that positive, you know, if they're asymptomatic, they need to be out of work for 10 days. So we had the question come up again just earlier this week with a resident who had tested positive to see if she was negative now. And what I tried to explain, it doesn't change the strategy in terms of the isolation period of time that they need to remain in once they have that positive test. So, you know, I think that has been a point of some question that I've noticed over the past few weeks. So I'd offer that up if anyone else had. I see another comment in the chat about that. We've really moved away. I think what happened was, and Dr. Ahmad was right in the middle of all of this with many of the nursing home residents getting retested for, you know, being free of COVID, is that many of them, they were getting tested, you know, 30 plus days out and still testing positive. And so really the guidance has moved away from a test-based strategy to declare someone no longer infectious. And if you think about it, you liken it to the flu. We don't go back and test people to say, oh, you know, you're over the flu, you're not infectious, right? So this was kind of a quirky thing early on in the disease where we were doing all of this retesting to try to determine if someone was safe to come out of isolation. And I think moving away from it and setting some clear guidance on how long it's likely, how long we know the virus is likely to be alive, and when it's, you know, no longer alive and may still be sampled from the nasopharynx, for example, but it's just the particles and not a live virus, has been really helpful in creating a more uniform strategy than this repeat testing. And then what do you do with these positives when they're 40 or 50 days out from their first positive swab? So that's just one observation I can share from the field so far.
And there's another question that came in. Crystal is asking about new admissions that test negative. Is there a benefit to retest in 7 to 10 days to see if it remains negative so that you can remove them from precautionary isolation?
I think we should, if they remain asymptomatic and their first COVID is negative, you should kind of think of them as a yellow zone patient and stop their transmission-based precautions after, according to what the CDC recommends, provided they do not develop any new symptoms in that interim period. That's what we're doing in a lot of our facilities.
Right, and the 14 days is you know the time where if they did have it and they were going to become symptomatic, that you would be seeing that, and it also would account for you know the time where they may also be potentially infectious unless someone in the yellow zone exposed them, which is you know generally with the full PPE on is unlikely that you're sharing that amongst the residents. So we have not been advising, nor is there guidance about retesting those hospitalized patients after they have that test performed prior to their discharge. We've just been keeping them on their 14-day quarantine in the yellow zone with the staff in full PPE, and then allowing them to come out of that yellow zone at that time.
Again, if there are questions or comments, feel free to unmute your microphone or you can use the chat.
So I'm just reviewing the document from cdc.gov on July 22nd, which is right after these new non-test-based recommendations to discontinue transmission-based precautions came out. And basically the key findings that they saw in their studies were that the concentrations of the virus measured in the upper respiratory specimen decline after the onset of symptoms, and the likelihood of recovering replication competent virus also declines after the onset of symptoms. So patients who have mild to moderate disease, no one has recovered replication competent virus after 10 days following symptom onset. And then recovery of replication competent virus between day 10 and day 20 after severe symptoms is also very low. So that is why they feel that even if you test positive, the chances are that that virus particle is no longer capable of contagion. They're also quoting a large contact tracing study for high-risk households and hospital contacts that no one developed infection if their exposure to a case started 6 or more days after the patient's illness onset. So, you know, as we're learning more and more about the virus, some of the recommendations have changed. But I think one thing to look forward to is I think we're probably looking at wearing face shields or goggles, even in your green zones, just like a surgical mask. This may be the new normal.
There's a slightly different twist in the conversation now. Is there such a thing as a false positive result? And if so, how are those results being confirmed?
So false negative is stated to be 1 in 5. If I'm, and I'll let Dr. Osavala chime in. I have not spoken to our infectious disease doctors about a false positive, but I've heard of them. Nikki, do you want to weigh in on that?
Yeah, so I actually, and this is just recent understanding after having participated in some of the DOH calls, there are some false positives out there. They're not nearly as common as the false negatives, which Dr. Ahmad is right. It's between 1 in 4 and 1 in 5. So, you know, it's much more likely that you have a false negative than a false positive, but they are out there. It is very difficult because once you have that positive, as I mentioned earlier, retesting a few days later and then having it be negative is not a safe strategy to then relinquish that person from their isolation. But I think this is more in the epidemiologist infectious disease realm where I think we'll hopefully gain better understanding of why some of those tests are showing false positive. Could it be that it's picking up other types of coronavirus, which there are many other strains of coronavirus that isn't the SARS-CoV-2. And I think in many cases, they've linked it back to certain labs. So, you know, that I don't understand if there's cross-contamination or if it's something with the equipment, reagent, et cetera. But there is such a thing as a false positive, but I worry much more about the false negatives. The nuisance of the false positive is that all of the happenings that occur in your facility and to the human being that tested positive after that in terms of the isolation. But from a public safety perspective, it's the right thing to do is just to presume that it is positive because they're far less common than the false negatives.
And if you think it's a false negative and you're suspicious that it's COVID, you should treat the patient as if they have COVID and apply the same criteria. That's what the hospitalist service is doing at Penn State, and I think that's what a lot of other institutions are doing. In this day and age, if someone has a fever, cough, and COVID is raging all around us, you really should be thinking of that. I'm not saying don't rule out UTIs, don't rule out sepsis, don't rule out pneumonia. You should be doing all that, but COVID should be probably one of the first things in our minds when people run a fever or develop symptoms.
And thank you for that question and for your responses. Crystal has another question. Are there plans in the works to create facilities or locations to isolate patients off-site from a negative facility?
Mm-hmm. Yeah, I can take that. At least for our South Central region, we have 2 alternate care sites that we have established. The challenge is, as this universal testing is happening in the nursing homes and in assisted livings, turns out there's a lot of asymptomatic staff and residents popping up. And we would very rapidly exceed the capacity, even if we, you know, had an apartment building, I would imagine, to try to move all of these people out, because you have to remember, even if you have, especially if the person is found to be COVID positive in place, you leave behind the entire yellow zone of any staff or any other residents that person may have been around. However, for smaller sites, for example, who maybe had a resident develop COVID, everybody else is tested negative, and there really is no safe way to isolate cohort. Maybe it's a dementia resident who won't stay in their room, won't wear a mask. In those scenarios, that's exactly what these sites would be meant for, are for those challenging patients to isolate, either because your physical structure does not allow for a safe red zone, or if the person themselves would not be compliant with being isolated after they return to your facility or within your facility. So there are plans now. Again, these are not apartment buildings or hospital-sized sites, and there certainly aren't any nursing homes that have kind of stepped up and said, we're going to make our whole nursing home for COVID patients. In some of the larger urban areas, that may be a strategy. But I think, our primary goal is to try to help administrators and DONs come up with a strategy to keep their resident in place, but when it really is not feasible, have that backup plan to move them. And in some cases, That could also be that they're coming out of the hospital and you'd prefer for them not to return because you're concerned about them being compliant with isolation or having a safe red zone to keep them in.
I'm actually wondering how many of the people on the call have faced COVID in their facilities. And I don't know how they'll respond. They can respond in the chat box or they can raise their hand. I don't know if that's possible.
So yes, feel free, if you're comfortable doing so, please put any comments or responses into the chat. Or again, if you'd like to open your microphone, you're welcome to share your story.
Yeah, because according to the data I reviewed, at least 867, so more than half of the facilities have been affected by COVID. Does that sound right, Nikki?
Yeah, it's I think and now with the testing, with the universal testing, we're kind of, you know, just uncovering what was likely simmering for weeks early in the pandemic, and our sites that had the big outbreaks are, you know, the asymptomatic staff and residents. But yeah, it's they're in large number, which is why I think we all have the fatigue of the PPE and the constant hypervigilance about hand hygiene, and why we can't let up, because it's still, if not anything, it's even more entrenched in our communities. And so any kind of releasing of those mitigation strategies and the strong infection prevention measures are going to open your home up. And the only thing we're doing right now is we're uncovering it a lot sooner and putting those measures into place to kind of keep it at bay. But I can see what's coming up in the chat here. It's devastating when it gets into your facility. And what was so tragic early on is that you really didn't know it was there until you had a symptomatic resident or staff member. And by the time you went and started testing, you know, it was usually a dozen. And by the time you were done, you could have 30 or 40 residents sick, maybe a third of those pass away. And it's, you know, it's terrible. And so while I've spoken with, I think maybe even some of you already, the frustration of doing this facility-wide universal testing, which is painful. Some of you have really big sites, and it is a monumental task to complete it. What you're doing is kind of uncovering the presence of the virus before it really infiltrates and catches one of the most vulnerable residents and then kind of spreads like wildfire in the facility. So it is a balancing act. And I think, you know, I'm so impressed with the commitment of the nurses, the DONs, the administrators to getting it right. But I also know it's, you're all tired. It's, I mean, work in normal times in nursing homes and long-term care is tough. And this is, you know, one millionth fold, I think, what you've ever had to deal with. So I feel for all of you. And, you know, again, I think the surveillance testing, as painful as it is, may be the best way, the best approach we have to keep our staff and residents safe.
So I just want to respond. I see a lot of comments about positive COVID. And Margaret, I identify because some of like our outbreaks in the facilities also started with, and this is back in early April when, you know, we were not as prepared as we thought we were, that you would have a swing of deaths and then a positive patient, and then you would realize, oh my God, COVID is here. And those first few weeks are very traumatic when you lose your long-term care patients. I just want to answer one question by Juliet. Let me see if I can pull it up. About, recovered patients, COVID recovered patients testing positive again. So I have seen patients who continue to test positive and may have some lingering symptoms. And by week 3, their symptoms resolve, but their testing continues to be positive. So far, at a personal level, I have not seen a COVID recovered patient develop another illness and test positive after testing negative or after being declared recovered. I'm not sure if Dr. Osivala has anything to add to it.
No, I've not seen anyone who had COVID have a new symptomatic presentation of having a secondary COVID infection. And I honestly don't know if I've seen that I think there may have been 1 or 2 published case studies of that, but I think largely for right now, we're not seeing that. Now, if immunity wanes 6 months from when they were first infected, could they be vulnerable come the fall if they had it in May? Perhaps, especially in elderly who they mount the same immune response and then hold on to that long-lived immunity. They may still be vulnerable come the fall, even if they survived it in the spring.
Another question is, what is everyone's experience for testing turnaround time? I think 3 to 5 days, sometimes a bit longer. One of our facilities acquired a machine just recently with a 15-minute turnaround time. So I'm excited to see what that will do for our surveillance testing. But you're right, we're not seeing 24 to 48 hours for a lot of our commercial labs. And I think that's because there's such a national burden from the Sun Belt states that have overwhelmed their capacity. I don't know if there are providers, including nurse practitioners, PAs, nurses who are going through weekly surveillance testing. Our group gets tested weekly. And there was a time when our turnaround time went from the regular 48 hours to 7 days, which really makes it a very useless test. But it has improved back to 48 hours again. So I'm not sure if the rest of the providers, what they're experiencing.
Are there any other questions or comments, either from anyone who's participating or Ayesha and Nikki? Do you have anything you'd like to ask of the group?
I think I'd like to tell the group one thing, which is if you're COVID-free so far, that's great. But be prepared. It's sometimes just a matter of time. The best run facilities have been affected. The most well thought of cohorting plans have been inundated. And another point I want to make is once your facility has recovered, don't relax. As soon as you relax on the PPE and what happens is, the nurses and the providers become a little lax when they're taking breaks. They let the face shield off, which I'm guilty of at times. I think it's just an Achilles tendon. So even if your facility has been through a terrible outbreak, it could have another outbreak, and that would be devastating in the new patients who previously did not have COVID, or in the previous patients who remain negative somehow through that. So just don't let your guard down.
So comments or thoughts on the question that's just been posted. Would it be acceptable to keep all residents in yellow and wear full PPE at all times to keep everyone else safe?
That's a great question. I'll comment just because I had this question earlier this week at a site. I think the biggest challenge is we don't know if we have enough PPE to get us through a big surge in the fall. And I do worry a bit about use of PPE in a protective fashion if you truly are green, and then not having the N95s, the gowns, because I heard the horror stories in the spring when people were buying rain ponchos. They were receiving, emergency shipments of, gowns that didn't have, holes for the arms to come through. They were, you know, wearing garbage bags, and we don't want to get to that place again. And so I guess, you know, my caution is, you know, while, yeah, that would be a great approach in a scenario where we had unlimited PPE. That's not the scenario we are living in the state, in the country. And so it's a precious resource. Now, that being said, and any site that I've worked with may have heard me say this already, I tell the staff, if you haven't washed your hands 100 times by the time you leave from your shift, you have not washed your hands often enough. This virus enters through your holes, right? So you cover your holes, you cover your eyes, you cover your nose, you cover your mouth, and you wash your hands constantly. It gets in there. Yes, there, you know, there is thought that perhaps there are some particles that are aerosolized, but largely we think that it is droplet. And so any surface you touch, and then you touch your face, even if you're touching your PPE, and then take it off and you don't wash your hands, and then you rub your eye, you know, when you get in your car, you have to be so meticulous. So I think the focus on the PPE is extremely important, especially around the residents, but I think it's that hypervigilance about hand washing, about not touching your face, not touching the PPE, and tons of hand washing. And I know that, you know, you should wash your hands 100 times during your shift sounds extreme, but I think it's a very simple message to get across to staff just how often you need to be washing your hands to prevent you from inadvertently contaminating your face, touching your eye, your nose, your mouth. And so, you know, my feedback would be, yes, that would be great if we just all had enough resources to, you know, behave as though we're in a yellow zone and change out gowns between residents, and that we could toss our PPE, you know, our masks after each use, but we're not by any means there yet. And so I think the strategy with the green zone, a surgical mask, I would not be wearing cloth masks at this point. I had a facility a few weeks ago that they were still wearing cloth masks, surgical masks, even in personal care homes. And, you know, there's not guidance yet, but I think it will be coming for eye protection. And the shield is the best because it also offers protection for the front of your, you know, over your mask as well. Not that goggles aren't good, but, you know, I think that those are the best strategies to really be as safe as we can with the resources we have right now.
Also, I think there is something very rewarding about declaring patients recovered when you're discussing it with their family members. And it just is good for the morale of the facility when, you know, a whole unit recovers and they're green. So, but I understand caution dictates that at least mentally we should think that people are in yellow, and maybe not the gown and the N95, but at least surgical mask and eye shield should be the new norm. That is our new look now.
We are almost out of time. So if there are any last questions or comments, please feel free to put them into the chat. And again, we will follow up with them via email. I'd like to thank everyone for your engagement and participation. As Michaela indicated, we have a link for our session evaluation and participant resources. We will be sharing that via email. If you are claiming CME credits, you do need to complete the evaluation to do so. And finally, you know, we'll see you again on August 20th at 2 o'clock.
Thank you.
Thank you all.